so much. Thank you so much for having me. And thank you so much for Wilson Disease Association of having us as the last Center of Excellence nominated last year or 2 years back. But it is our pleasure to have all of you here in town. And I just came back from China. I know we have folks from China. I know where they are. 你们好，你们好呀，高兴见到你们呀。那会儿中午吃饭的时候会有时间的。All right, so I just said welcome to them. Yeah, so usually it takes longer than an hour and a half to get to the brain. To just about all the conferences I have been through. The last one I went was the Heart and Brain Association in Vegas, and took them 7 hours to get from the heart to the brain. But that was a joke. Okay, so let's get started. So yeah, I don't want to repeat what have been said so elegantly by the previous speakers. So we're going to move on to the heart or the core of these slides, which is a case. Now it's a little too far for my young eyes to read it from here, but I'll try to read from here. I remember this was 15 years ago, and thank you so much, whoever is doing the enlargement of the slides to accommodate young eyes, and it worked really well. I received a call from one of our local or primary care doctors, and he said, can you see a patient next week? I said, wait, next week? I don't have anything, and you guys know I don't have anything for 3 months if we're lucky that it's open. He said, no, this one, you have to see it next week. Can you just do it for me? I said, what happened? He said, I made a boo-boo. I said, what did you do? And he said, well, it turned out to be, I think he has Wilson disease. So delay in diagnosis. Now, 15 years later, and I had a case, and I pulled from the American Academy of Neurology, recently published here. It says 15-year-old female with first or new onset of seizures. He actually showed up at one of the local emergency rooms and on the East Coast, and then he was admitted to the hospital. She was admitted to the hospital, and then she was put on seizure treatment, and the EEG at the time showed what is called the focal discharges from the brain. In this case, was coming from the temporal areas, or temporal lobe on the left side of her brain. And so she was young, and she had other symptoms. So she had what is called bradykinesia, which is a slowing or slowness of movements. And she also had some other systemic findings, and then the physicians at the intensive care unit suspected that she had something else going on because they couldn't find why she was seizing at the age of 15 without any other history of neurological history. So they did a brain scan, and the scan showed the following. So on the far left, far right, or actually far left, and the A and B shows the significant signal reduction, what is known as hypointensity in the basal ganglia bilaterally. So it wouldn't be typical of a seizure disorder. Then she had other workup, included the serum ceruloplasmin and serum copper. Both levels were low, and she had also elevated urine copper. Further on, they tested her for exon sequencing and revealed the true cause of her illness, and that was considered to be pathogenic ATP7B variants were found. So this was a late diagnosis too, but not as late as the first case I had to take care of, and then further on and the patient moved to the East Coast, and we have no follow-up at that time. So 2 cases separated by a time span of 15 years, and then it's illustrated the same principle. That is, these patients can present in anywhere, in neurology office, anybody's office, primary care office, with non-hepatic presentation. And it can turn out to be Wilson's. So we have to think about Wilson. If we don't think about Wilson, we will miss it. So what are the clinical features? It's been very well said in the previous elegant presentations. Neurological presentations is wide, but primarily under the category of movement disorders. What are the movement disorders? They can have tremors, they can have dystonia, they can have Parkinsonism. In fact, tremor, dystonia, and Parkinsonism would have just about, or taking up 90% and 90%, or not even more, cases that are neurological of Wilson's. And they also can have psychiatric, and I don't believe we have actually psychiatric presentation or on psychiatry presentation, but we'll cover the basis. So neurological manifestations would have the age of onset vary significantly. The youngest has been 6, and the oldest have been reported as 72, last time I looked. Most common, again, tremor, dystonia, Parkinsonism, ataxia can occur too, dysphagia and dysarthria, and even sialorrhea. They can be aggravated by emotion, stress, and medications. They can diminish or even disappear during anti-copper treatment, and that's actually a good thing. So if these patients can be diagnosed and put on copper chelating agents, and their neurological symptoms in general can improve. So specifically, the tremor can have a variety of types, and unfortunately, they can mimic something like Parkinson's disease. So these patients, more common than not, get diagnosed with Parkinson's first, and then turned out to be Wilson disease. And those cases can have what's called resting tremor. So rest tremor is a pronation, supination type of tremor, as opposed to the postural tremor, which is stretching arm out, and they have what is called wind beating. Now, only a minority of these cases actually presents wind beating tremor, and that would signify the diagnosis of Wilson's. Unfortunately, they can have so many types of tremors, and even kinetic tremors. 55% initial presentation, 90% of them eventually have as a part of the clinical presentation. Delay in diagnosis up to 6 years. Again, in the previous case, was actually more than 6 years of a delay. So management, on the tremor management, the classic medications that have been prescribed to these patients are listed here. Feel free to take photographs. And the propranolol, which is a beta blocker, and clonazepam and gabapentin, and even primidone, all have been used with various degrees of success. Side effects also vary based on the different classes of medications, especially when these patients, when they're younger, when they have also concurrent hepatic issues, and you have to, of course, co-managing these patients with your liver and GI folks or comproviders are going to be the key. Dystonia, though, can present also quite commonly, and they can be focal, meaning one area, such as hemifacial, even one single limb dystonia. We actually have one patient who had one single limb dystonia. And they can have generalized dystonia even up to the dystonic storm. When they are in dystonic storm, they would require ICU level of care. And these patients can be managed accordingly with classic antidystonic medications such as anticholinergics. This one is exemplified by THP, the trihexyphenidyl. And baclofen has been used, and even botulinum toxin. And some of our patients are receiving Botox injections. And the nice thing about using Botox in treating dystonia is that they don't have to be having the same level of concern in terms of affecting liver function or any other systems as a whole. DBS has been used, deep brain stimulation, has been used to treat dystonia, and these stimulators would be placed into the specific areas that are affected in Wilson disease, namely basal ganglia. Parkinsonism can happen or can occur in 20 up to 62% of cases. Can have classic cardinal signs. That will be probably the biggest mimicker that we have in the world of movement disorders, in that they can have rest tremor, they can have bradykinesia, they can have classic gait issues or instability with their walking and balance issues. They can actually have the initial response to dopaminergic interventions. If you put them on carbidopa, levodopa, make sure they're protected with carbidopa though, because of their potential liver implications. So moving on to the other neurological manifestations, dysarthria and dysphagia would require co-management of their neurological manifestation. Wilson disease, dysarthria could benefit from relaxation techniques, and speech rate therapy could benefit cerebellar type of ataxic type. And the speech rate therapy is what's also known as pacing speech. Loudness and the speech rate therapy is the pacing, and loudness and articulation techniques for the hypokinetic type, and augmentative communication devices for the more severe types of dysarthria have been investigated. Dysphagia can lead to aspiration pneumonia, so we need to plan ahead. If the patient started to have dysphagia, prevention would be the key. Now, the way to prevent aspiration pneumonia can also vary from according to the severity of their dysphagia, and sometimes Botox injections can also help to lead to prevention of aspiration pneumonia by virtue of decreasing their saliva production. Behavioral and psychiatric issues can co-occur with neurological manifestation. They range from mild depression to full-blown psychosis, can affect up to 30% at the time of diagnosis. 16% can also attempt suicide, so can be quite severe. Avoid drugs that may damage liver function, and this is a list of drugs that may actually cause liver function damage. We have to be very careful about monitoring these patients if they are on these medications for their behavioral and psychiatric issues. Other considerations would include restless-leg syndrome, neuropathies, headaches, and tics and myoclonus, and even seizures, as we alluded from the very beginning of the presentation. In conclusion, neurological symptoms of Wilson disease can be subtle initially and severe as the disease progresses. High clinical suspicion can lead to early diagnosis and proper referral and intervention. Early empiric treatment modalities with copper chelators and symptom-based management have been demonstrated to decrease symptoms and disease severity without increasing neurotoxicity. Last but not least, further studies can help researchers and clinicians better understand the complexities of Wilson disease and gain additional understanding of a new emerging therapeutics, I believe we have the next section to be on the emerging therapies. Thank you so much for listening.